Very good evening, everyone. So we are back with the Farre series of fourth prof, and this is the sixth lecture of pediatrics. And here we are going to discuss respiratory system. Hello, Arbaz. Hello, Ayush. Hope you had a good day and a very good evening. Okay, so without further ado, let's start. So, when we talk about respiratory system in pediatrics, you are going to expect long and short notes on pneumonia, cystic fibrosis, asthma, infections like epiglottitis, pertussis, and a miscellaneous topic, foreign body aspiration. We are going to discuss it here only. Right, so without further ado, let's start with the most important topic, that is pneumonia. Pneumonia is something that you will encounter very frequently, especially in the winter season. So, you are going to have a lot of patients with pneumonia like presentation. And also, if you are working as an MO at a PHC level or a CSC level, then you should know the IMNCI guidelines, when to refer the child, when to give home-based treatment. Good evening, everyone. Good evening, Nandini. Good evening, Sannyasi Pandit. Good evening, Dr. Uday Place, Dr. Feroz Abbas. Good evening, everyone. So, without further ado, let's start with the most important topic, that is pneumonia. So, when we talk about pediatric pneumonias, what do you think is the most important cause? Is it the bacterial pneumonia or the viral pneumonia? When we talk about diarrheas, then viral diarrheas are more common. But when we talk about pneumonias, then bacterial pneumonias are more common as compared to viral pneumonias in pediatric population. And amongst bacterial, the most common bacteria that is responsible for this pneumonias is Streptococcus pneumoniae. And in cases of virus, the most common viral infection is RSV, respiratory syncytial virus. They also ask what is the most common culprit in cases of opportunistic infections like immunocompromised patients, HIV, AIDS. In those, it's Pneumocystis jirovecii. Pneumocystis jirovecii. And if they give you an atypical age group like adolescent age group, then it is mycoplasma pneumoniae. So these are the one-liners frequently asked. These can be your viva voce points also. But what they ask in the theory exam is the IMNCI guidelines. What are the IMNCI guidelines regarding pneumonia? Right, so IMNCI guidelines. Before we go into the guidelines, you should know what is fast breathing. What is fast breathing and what are the danger signs? So when will you say that this child is breathing fast? That depends upon the age of the child. In between 0 to 2 months, if the respiratory rate is more than 60 per minute, then it is considered as fast breathing. 2 to 12 months, more than 50. And after 12 months, more than 40. So 60, 50, 40. So this is the criteria for fast breathing. And what are the danger signs that you need to know? Whenever these danger signs are there, the child is going to have severe pneumonia and you need to refer this child to a higher center. So what are the danger signs? If the mother says that the child is unable to drink because of the respiratory rate effort, the child is unable to drink, that is a danger sign. If the child is having seizures, convulsions along with the respiratory distress, this is a danger sign. If you encounter a calm child but this calm child has stridor, that is a danger sign. Right? If the child is very lethargic, very abnormally sleepy, very dull, that is a danger sign. And lastly, but not the least, if the child has severe malnutrition, then this child has a danger sign, right? So, severely malnourished child, if the child has severe malnutrition, this is yet another danger sign. So these are the basics that you need to know before going into IMNCI guidelines. You should know what is fast breathing and what are the danger signs. So with that in our mind, with that knowledge as our base, let's begin. the IMNCI classification. So when we study diarrheas and dehydration, we have no dehydration, some level of dehydration and severe dehydration. But for pneumonias, you don't have some pneumonia, something like that, right? Either there will be no pneumonia, or there will be pneumonia, or there will be severe pneumonia, right? So no pneumonia, there will be pneumonia and severe pneumonia. Severe pneumonia, right? So what are these? What is no pneumonia? What is the pneumonia? What is severe pneumonia? So when we talk about no pneumonias, these are given the label green. Green. These children don't have pneumonia. They just have some upper respiratory tract infection, can be managed conservatively at home. Then we have pneumonia, yellow. These children definitely have pneumonia, they have infection, but it is not that severe that we need to admit this child. We can treat this child on OPD basis, give some oral antibiotic, tell the caregiver about the danger signs, so that when as and when required, the mother can follow back or the caregiver can follow back. And lastly, we have severe pneumonia, that is red. This child has severe infection. You need to give stat antibiotic and refer this child to higher center for further management, right? So with that knowledge, so what will happen in no pneumonia? I told you there is no respiratory distress, just some upper respiratory tract infection or affection. So the symptoms here would be just some cough, fever, cold-like symptoms, right? No respiratory distress sign, the saturation will be normal. The management is nothing, just supportive care has to be given. Home-based treatment. You can send the child home, and if there is fever, you add paracetamol. If there is wheeze, you add salbutamol. The supportive treatment. What about pneumonia now? This pneumonia child is also going to have cough, fever, cold. Apart from that, there will be respiratory distress signs. What type of respiratory distress signs you can see? You can see fast breathing, or you can see retractions, chest retractions and drawing of the chest, right? So you can see fast breathing and or retractions. But the saturation here is going to be normal. Here, as the child has pneumonia, I have to give antibiotics, but I can send the child home. Here also, home-based treatment is going to be there. You give oral antibiotic, oral amoxicillin for 5 days. Oral amoxicillin for 5 days, and ask the mother to follow up after 5 days, right? And also counsel about the danger signs. If danger signs happen, then the mother has to come earlier, right? So counsel about the danger signs. What about the 5 danger signs that we studied just, right? So you tell the mother about those danger signs, that if the child is not able to drink, the child looks abnormally sleepy, the child has some sort of convulsions, then you have to come sooner, before 5 days, right? Lastly, severe pneumonia. Here again you will have these signs and symptoms, and along with these respiratory distress signs, there will be danger signs. There will be danger signs. If any danger sign is there, it is directly severe pneumonia. Here the saturation will also be dropped. Saturation will be less on room air. Less than 92% saturation can be appreciated. Here the child has to be treated in a hospital setting. So what do? You give a stat antibiotic injection ampicillin and gentamicin, and then refer to higher center immediately. So this is about the IMNCI classification, no pneumonia, pneumonia and severe pneumonia, and their management. Now there are two terms that the examiner can throw at you. What are recurrent pneumonias and what are persistent pneumonias? So what do I mean by recurrent pneumonia? Recurrent pneumonia means bar ho raha na, recurrent. So if there are two or more than two episodes in 1 year, or there are 3 or more than 3 episodes in the lifetime of that child. 3 or more than 3 episodes in lifetime. This is the definition of recurrent pneumonia. Then we have persistent pneumonia. Persistent, the term itself has persistent in it. That means this pneumonia is not getting resolved, not getting treated. Usually, when there is pneumonia, you see the evidence of that infection on X-ray, and this radiological evidence should go within 1 month. But if this radiological evidence is persisting beyond 1 month, this is known as persistent pneumonia. So, presence of radiological evidence for more than 1 month. So, in which all children do we see this recurrent pneumonias and persistent pneumonias? So, that means these children are getting again and again infection, and whenever the infection is happening, it is persistent for a long time. So, these recurrent and persistent pneumonias you see in a set of population. What are these set of populations? These risk factors include the children who are immunocompromised, like severely malnourished child. If a child is a SAM child, there are chances that this child will have recurrent pneumonias, persistent pneumonias. If the child has some sort of immunodeficiency, again this child is going to have recurrent pneumonias, which if this child has recurrent aspiration due to some issue, some congenital issue, there could be a constant GERD problem, or there could be some laryngomalacia or weakening of the LES. So in those conditions, CP child, right? Cerebral palsy child, some neurological problem, persistent pneumonias. Children with congenital heart diseases. Children where there is improper clearance of my respiratory secretions. One condition we are going to study today, that is cystic fibrosis, where there are thick secretions and improper clearance of that secretion. And because of that, there are recurrent and persistent pneumonias. So, cystic fibrosis, Cartigener's syndrome. This you must have studied in ENT. Right? So in all of these population, there are chances of recurrent and persistent pneumonias. So with that, we complete the section of pneumonias and move on to the next topic, that is cystic fibrosis. If there is any doubt regarding this pneumonia topic, which is a very important topic, so please drop that down in the comment section below. Right? Please drop that down in the comment section below, and we'll be more than happy to repeat it. Otherwise, we can move on to this next topic of cystic fibrosis. Okay, so let's start if there is no doubt per se. So what is cystic fibrosis? Cystic fibrosis is a genetic problem. The inheritance here is autosomal recessive. And you all understand, you have studied in the genetics section, if it is an autosomal recessive condition, what all scenarios you will see in autosomal recessive. You see a horizontal affection in the pedigree. Consanguineous marriage will be a risk factor, right? So consanguinity you will see, and you will see in pedigree that horizontal affection would be there. That means siblings would be affected. Siblings affected. What happens in this condition? There is mutation on chromosome number 7, long arm of chromosome 7. Here on this long arm of chromosome 7, we have a gene that codes for the CFTR protein. What is this CFTR protein? It encodes for a chloride channel. Chloride channel. A lot of mutation can happen in this cystic fibrosis, but the most common mutation that we see is delta F508. What do I mean by delta? There is deletion of phenylalanine at 508 position. So this is the most common mutation. What will happen because of the affection of this chloride channel? What this chloride channel does is, if this is my gland, then we have an intracellular space, we have lumen. So this chloride channel, what it does, it pushes the chloride from the intracellular compartment into the lumen. As this chloride goes into the lumen, chloride is a negative charge, To balance it, my sodium also follows. Sodium follows. And when we have sodium chloride, salt, water also follows. Right, so by this chloride channel, what is going to happen? Water is going to go into my lumen, so that will thicken out all the secretions and that would be easy to clear out. But if this chloride channel is mutated, what will happen to the mucus secretions? They will become very thick. They will become very thick. The mucus secretions will be very thick, very viscid. So that's why this condition is also known as mucoviscidosis. Mucoviscidosis. And because of that thick secretions that are very difficult to clear out, there will be recurrent pneumonias in these children. In the early life, which organism causes pneumonia here? Streptococcus or Staph aureus, Staph aureus. And later, it is the Pseudomonas which is the culprit, Pseudomonas. Right? If they ask you which organism, pneumonia by which organism has the highest risk of death in these patients, then that's Burkholderia pneumoniae, right? So risk of death is maximum with Burkholderia species. Burkholderia species. Right? So with that, we are clear with the inheritance pattern, the pathogenesis. Now let's look at the clinical features. Clinical features you all understand. First would be the wherever there are secretions, that secretions are going to be thick and that would lead to problems. Respiratory, you have understood, there will be recurrent pneumonias because the child is not able to clear out the secretions. There will be also formation of nasal polyps. So with one by one we will go through the system. First system, let's understand GI, gastrointestinal system. So in a newborn, the gut also produces secretions and the stool has to pass through. But here, because of that thick secretions, what will happen? There will be meconium ileus. Meconium would be very thick. So earliest manifestation that you see is meconium ileus. Later on, this child is going to have constipation. Right? The child is going to have fecal impaction, intestinal obstruction, and rectal prolapse. Rectal prolapse. So fecal impaction. And intestinal obstruction. There will be rectal prolapse. So this is all about the clinical features affecting the gastrointestinal tract. Now let's move to respi. Respi 1 you understood, there will be recurrent pneumonias because of these thick secretions that are very difficult to clear out. Recurrent pneumonias and bilateral nasal polyps. Apart from that, my glands, other endocrine glands would also be affected. Pancreas would be affected. Both endocrine and exocrine part would be affected. Endocrine, we all understand insulin production is the main calm of pancreas. So if endocrine function is affected, what will this child is going to have? The child is going to have type 1 DM. This type 1 DM is usually seen in the second decade of life in these patients. And because of the exocrine insufficiency, what will happen? Exocrine, we have trypsins, we have lipases, amylases. So all the fat soluble vitamins won't be absorbed and there will be steatorrhea in this patient. Steatorrhea in this patients. Like greasy stools, foul smelling. Right, apart from pancreas, let's move down to the liver now. In liver, we see neonatal cholestasis because of the stasis of bile. Fertility in males, we see azoospermia. And what will happen to the sweat? Because this chloride channel is ulta here in the sweat. What it does, it takes chloride into the intracellular compartment. So this sweat, because the chloride channel is defected, is going to be very salty. So this child has very salty sweat. So mother says, whenever I am kissing the child, I feel that my child is very salty. have a very salty taste while kissing the child. So these are the clinical features and the manifestations that you see here. Now let's move on to the diagnostic criteria. What is the diagnostic criteria for cystic fibrosis? First diagnostic criteria says that there has to be these typical clinical features that we just discussed. Typical clinical features. Also, we know it is a genetic problem, autosomal recessive, so there should be history of clinical features in family members or sibling. And confirmation is by lab test. Which lab test? What is the gold standard? Gold standard is sweat chloride test. Sweat chloride test. We check the sweat chloride levels. If we have two abnormal values on 2 days, 2 occasions, then we label it as having cystic fibrosis. What is the abnormal sweat chloride test? What is the abnormal value? More than 60 milliequivalents per liter is the abnormal sweat chloride levels, and if two abnormal values are there on 2 days, this is diagnostic. The other lab test is checking for the cystic fibrosis mutations. I told you there are multiple mutations in cystic fibrosis, and the most common is delta F508. So if you document 2 cystic fibrosis mutations, this is diagnosis. And last but not the least, we can check the transepithelial nasal potential difference. If that nasal potential difference is less than minus 40 millivolts, then it is an abnormal value and diagnostic of cystic fibrosis. So confirmation is by any one of these lab tests. So this is all about the diagnostic criteria. Now let's move to the management. Management is very supportive, right? This is a genetic defect. We cannot do much. What we can do is to support the health of the child. For respiratory systems, you give chest physiotherapy so that the secretions can be cleared out. To thin out the secretions, we can add on mucolytics like 3% saline. Also, we have recombinant DNAs. Recombinant DNAs, Dornase alpha, that can also help in thinning out of these secretion. We know Pseudomonas is a very important culprit in causing pneumonias over here. So we can give preventive prophylaxis for Pseudomonas infections. We can give inhaled tobramycin. Or we can add oral azithro. And if the child has full-blown pneumonia, as the needless to say, the child will need antibiotics like co-amoxiclav. Right. Apart from that, as the GI is affected, we have to make the dietary measures for the same. Pancreas is affected, there is steatorrhea, so losses are there. So we have to increase the diet in fats, protein, calories. We can add on, give supplemented pancreatic enzymes and include fat soluble vitamins like vitamin A, D and K. Then comes the pharma question, which can be your table viva question, placard question. CFTR modulators, name that CFTR modulators. So remember, these are cafters. Caftor stand for CFTR only, caftor, right? So these are EVA caftor, Lumi caftor, Teza caftor, right? Alexa caftor. These are the CFTR modulators. So with that, we complete the section of cystic fibrosis. This is a fairly easy topic. With that, let's move to the next topic, that is bronchial asthma in children. When we talk about bronchial asthma in children, they majorly asked in the exam the management of bronchial asthma, nothing more than that. But you should know what is asthma. If there is a long note, you have to tell about the definition of asthma, the diagnostic criteria in pediatric asthma, which is different, slightly different in the value wise from the adult asthma, and then later on the management of asthma. In management, they can give very well a long note also, a short note also, because there is something known as the acute management and something known as the long-term management. Acute management would be managing the asthma attack that is happening when the child is coming to us in the emergency. And long-term management would be the child is recurrently landing up in emergency with this attack. We need a baseline therapy for the long-term management of these child. So long-term management, so that later on the child does not develop a COPD-like condition. So without further ado, let's start with this topic, that is bronchial asthma in children. Bronchial asthma in children. Okay. So let's start with bronchial asthma. What is the other name of bronchial asthma? Bronchial asthma is actually a reactive airway disease that in response to a trigger, there is going to be bronchoconstriction. And this bronchoconstriction, as soon as the trigger is gone, will be relieved. So there is reversible bronchoconstriction. Reversible bronchoconstriction. And whenever there is bronchoconstriction, my lower airways are going to will get constricted, so there will be wheezing like sound. So because of these reversible bronchoconstriction that happens in response to the trigger, there will be recurrent wheezes in this child. This all happens in response to triggers. These triggers could be anything: dust, pollen, animal dander. And we see a typical diurnal variation over here, that as the temperature drops, there will be more chances of these bronchoconstriction. So when the temperature drops, whenever late at night, very late at night, and very early morning. So you see a very typical diurnal variation, either in the night time, late at night, this child develops this asthma-like symptoms, or very early morning, this child develops these asthma-like symptoms. So diurnal variation is seen over here. You see the more of these exacerbations late at night and early mornings. Daytime, the child would be fairly fine. Okay, so this is all about the definition. Reversible bronchoconstriction presenting with recurrent wheeze in response to these triggers and have a diurnal variation. It is a reactive airway disease. Now, what are the risk factors for asthma in children? Firstly, the risk factor is gender. Male children are more predisposed to this asthma. Low socioeconomic status is also considered as a risk factor. Low socioeconomic status. If parents have this history of allergies, asthma, then the child is also going to have higher predisposition of asthma. So parents, if there is history of any allergic diathesis or asthma, it is very common that the child is also going to have such allergies and asthma. If the child himself or herself is allergic, there is, let's say, atopic dermatitis like conditions or sinusitis like conditions, then again the child is more at risk of developing asthma. And smoke exposure is also considered as a risk factor for asthma. So these are the major risk factors that we see in pediatric population. Now, types of asthma, this you have read in thoroughly detail in the path also, in medicine also. So you all understand we have extrinsic type of asthma, intrinsic type of asthma, drug-induced asthma, exercise-induced asthma. Drug-induced, exercise-induced need not need any explanation. They are self-explanatory. Extrinsic, you know, in extrinsic, the trigger responds to this IgE mediated reaction, and intrinsic non-IgE mediated reaction is there, right? So with that, let's move on to the definition of pediatric asthma. So one liner part question can be given. So if it is a long question, they can ask you, tell about the definition of asthma and the management of asthma. So definition is going to have 2 or 3 marks and rest is going to have the management. So what is pediatric asthma? What is happening in pediatric asthma? Is it an obstructive disease or a restricted disease? What is happening? There is bronchoconstriction. So there is obstruction to the airflow. So what will happen when the child will expire? The FEV1 will be less as compared to the FVC. So it is, you will see decrease in the FEV1. So FEV1 to FVC ratio, if it is less than 80%, less than 0.8, it is considered in the definition of pediatric asthma. We know asthma is a reversible bronchoconstriction. So if we can show this reversibility by giving bronchodilator, that whenever I give bronchodilator, this FEV1 should improve. That means it is a reversible condition. So whenever we give bronchodilators, this FEV1 should improve. So on giving bronchodilator, if my FEV1 is increasing by 12% or more, it is included under the definition, right? Then we give an exercise challenge. By exercise, my broncho constriction should worsen. So my FEV1 should also decrease. So by exercise, if my FEV1 falls by 15%, it is considered as asthma definition. I told you there is going to be a diurnal variation. So if you see an AM-PM variation in the peak expiratory flow rate of more than 20%, it is considered in the definition. And lastly, inhaled NO, you all understand this. If it is more than 20 parts per billion ppb, then it is considered in the definition of asthma. So very similar to the adult definition, but the values here are slightly different. So this is basically the pediatric asthma definition. Now let's move to the management. I told you management part would be divided into two segments: acute attack, managing the acute attack, and managing the long-term management of this patient, where we will study about the stepwise approach. So firstly, the acute attack. Whenever a child comes to you with an acute attack, what you are going to give? SABAs, that are short acting beta agonists. So SABAs. Firstly, we start with SABAs, salbutamol. Either we can give through inhalers, you give puffs, or you can give nebulization, right? What is the duration of these puffs? You give 1 puff per minute, and you can go on till giving 10 puffs. Then nebulization comes. Nebulization we give 3 times 20 minutes apart. So as the child comes, 0, 20, 40. You tell the nursing staff that nebulize him right now, then nebulize after 20 minutes, and nebulize after yet another 20 minutes. So by the end of the third nebulization, you are going to then next assess. So 3 times 20 minutes apart. Right? Usually children respond to this therapy. But if the child is not responding with this, that means the child's saturation is dropping less than 95% and the VS is still persistent, then you start with oxygen therapy and add oral steroid. We add oral prednisolone. What is the dose that we give over here? We give 1 to 2 mg per kg per day, oral tablet. 1 to 2 mg per kg per day of oral prednisolone is given. After giving this oral prednisolone and continuing the nebulization, we reassess after 1 hour. So you reassess after 1 hour. Reassess after 1 hour. After reassessment, if the child is still not improving, then you have to start nebulization with Duolin. Duolin has both SABA as well as ipratropium. Right? And apart from nebulization, now instead of giving oral steroid, we give IV steroid. We start with injection hydrocort. The dose that we give over here is 10 mg per kg. 10 mg per kg of hydrocort is given. Then we reassess after 2 hours. Reassess after 2 hours. Now, if the child is not responding, I am going to now give theophylline injection. Injection theophylline, caffeine, right? Caffeine like theophylline injection. And MgSO4, that is magnesium sulfate. And if the child is still not responding, then the last resort is ventilate this child, intubate this child, and take this child on ventilator. So mechanical ventilation would be the last resort. So we have discussed the worst case scenario, right? If the child is not responding to my initial SABA, then I start with oxygen, add oral prednisolone. Not responding, add Duolin, injection hydrocort. Not responding, add theophylline, magself. And not responding, intubate this child. This is the final. So we have discussed the worst condition. But all the children don't land up into this worst condition. They will improve also. So if the child improves at this stage, you can discharge this child at home and tell that please take SABAs every 6 to 8 hourly. 6 to 8 hourly. Right? If this child improves after giving injection hydrocort, if the child improves after giving injection hydrocort, then you can again send the child home on SABAS. Along with that, we tell the child to take oral prednisolone at home for 5 days. Oral prednisolone at home for 5 days and stop after 5 days. We don't taper it. Right? So this is the management of acute episode of asthma. Now let's move on to the long-term management. So if a child presents to us with recurrent episodes of these asthma, recurrent conditions, so obviously his activity will be limited. He won't go to school that day, he won't go to play that day. And also these recurrent stresses can lead to further COPD-like picture in future. So here we need to give a baseline therapy so that the quality of life of this child improves. So here long-term management, remember, depends on two things. Firstly, it depends upon the severity. Depends upon the severity of asthma of this child. And secondly, this here in the long-term management, we go by stepwise approach. Firstly, we will give step 1, lesser things. Then if the child is not improving, then we can add on or increase the dosage. Then again add on and increase the dosage. So we will go in the stepwise approach. Right? Firstly, start with lesser drugs, lesser doses, and as the child worsens, we can obviously improve the dose, increase the dose, add on drugs. So there is going to be a stepwise approach. Right? Stepwise approach. So what is the stepwise approach? For that, let's understand the types, the severity. So we have two types majorly, intermittent asthma and persistent asthma. Intermittent, the name itself has. Here and there infrequent attacks are happening, right? So here and there the child is going to have very infrequent attacks and the child is very much normal in between the attacks. Normal between attacks, right? And because these are such infrequent attacks here and there happening and the child is absolutely normal in between, there won't be any activity limitation, no activity limitation. So these children just need SABAS along with inhaled corticosteroids whenever these attacks happen. Very simple. Then comes persistent asthma. Persistent asthma means this child definitely has persistent attacks. Depending upon how many attacks are happening in the daytime, in the night time, in a given month, and what is the activity limitation in this child, we divide this persistent asthma into 3 categories. This persistent asthma is divided into 3 categories, that is mild, moderate, and severe. Firstly, let's start with mild. When will I say this child has mild persistent asthma? Whenever in the daytime the child has 2 or more episodes per month, and in the night time more than 1 episodes per month. There will be mild activity limitation. Maybe the child has to miss some classes that day, maybe the child didn't go to play that day, so mild activity limitation. So here we start with SABAS. Along with, I will again add low dose baseline inhaled corticosteroids, SABAS and low dose inhaled corticosteroid. Let's move to the second category, moderate persistent. Here the child is going to have daily attacks. If daily attacks is happening, the child is definitely be restricted to his home. So there will be moderate level of activity limitation. Here, along with, now I won't give SABAS, I will give LABAS, that is long acting beta agonist, right? Along with that, I will definitely continue my low dose inhaled corticosteroids. Or what can I give? I can give medium dose inhaled corticosteroids, right? LABA plus low dose or just give medium dose. Then have the severe one. They're going to have continuous attacks. So definitely the activity limitation will be very severe. Here I have to give high dose of inhaled corticosteroids. So LABA plus high dose. LABA plus high dose. Plus we'll add montelukast, that is leukotriene agonist, right? Leukotriene antagonist, montelukast. And along with that, we have to refer to a specialist. Refer to specialist. So this is about the long-term management. Again, they can ask in the update section about the recent therapies. We have IgE inhibitors like omalizumab. These are tried in refractory illnesses. Interleukin 4 receptor antagonist dupilumab. Interleukin 5 receptor antagonist benralizumab. 13 ustekinumab. Interleukin 13 inhibitor is lebrizumab. And then we have interleukin 5 inhibitors, mepolizumab and resilizumab. Right, so these are the pharma drugs. They can ask you in the recent update section. So with that, we complete with our section of asthma. And asthma, I know in the section inhalers are a hit in the comment section. So what are these inhalers? So can you see this? You must have seen this, adults using here and there in the emergency section also. These are MDIs. That is metered dose inhaler. With each puff, a metered dose, a calculated dose only comes. A regulated dose comes. For children, because it needs a coordination to actively puff and take it inside. So for children, we need assisted devices. We have something known as spacer over here. We firstly prime the spacer and ask the child to breathe in and out of that spacer. And even smaller children, because they cannot make effective seal in the spacer, we have this mask. So three types. If a child is very small, if the child is less than 4 years, then we say you use these three together. You use mask plus spacer and then add MDI. If this is a child who is in between 5 to 12 years of age or 4 to 12 years of age, then the child can make a seal with the spacer only. You don't need mask much. Spacer plus MDI. After 12 years, we need directly MDI puffs for better deposition of the drug. And then we have these something known as rotailers, where you insert a capsule and the child then takes it up. After 5 years of age, the child can take these rotailers. So this is about the pointers of the inhalers and spacer, mask. Gostab is asking if is inhaler contraindicated in children? No, inhaler is not contraindicated. Why would that be contraindicated? That can improve the life of the child. You just need a proper technique to do that. Right? You will need a spacer or a mask depending upon the age of the child. So this is all about asthma, bronchial asthma in children. If you have any doubt here and there about asthma section, please drop that down in the comment section, or we can move ahead with two important infections, epiglottitis and pertussis. And after that, we have a small section of foreign body. Any doubt? Okay, so if there is no doubt, we can move ahead with epiglottitis. Epiglottitis, acute epiglottitis. The name itself has inflammation of the epiglottis, happens in the particular age group, most commonly seen in 1 to 3 years of age. A lot of bacteria can cause this, but the most common, most important cause is Haemophilus influenza. Haemophilus influenza. So the reason of asthma, I have already told you, multifactorial genetic risk factor is there. There is reversible bronchoconstriction. The pathogenesis, path people will tell, medicine people will tell. You have studied that in detail everywhere, right? If we go on to discuss on the pathogenesis of asthma over here, that will not do justice to the pediatric score. You need the management part in pediatrics, you need the definition part. The basics we have covered. This you should study in path. You should have been well versed over here, right? So moving down to, again, coming back to the topic, acute epiglottitis. Age group is 1 to 3 years of age. Cause is Haemophilus influenza type B. And what will be the clinical feature? So it is a very emergency like scenario. You will see a child who is very toxic looking, very sick looking child. So this child has a high grade fever, very high grade fever. This shall be very toxic looking, very sick looking. Can you see the image over here? Very toxic looking child, very sick looking child. When the child tries to speak, the voice will be very muffled. There is muffled voice. And there will be drooling of saliva. Drooling of saliva. And lastly, as this child is very sick, this child is going to have very severe respiratory distress. There will be cyanosis, retractions, and this child assumes a typical posture, a tripod-like posture. Can you see? The child is taking the support of both of his arms and sitting in a tripod-like posture. So it is a typical posture that you see, tripod posture, tripod posture. When you go on to do the x-ray in this child, what do you see? Normally my epiglottis look like this. But here, because there is inflammation, the epiglottitis is swollen and looking like a thumb. This is known as thumb sign. So you see a thumb sign in epiglottitis on lateral x-ray of the neck. The management is nothing over here. It is an emergency condition. The child is in severe respiratory distress. So you first stabilize the child, do A, B, C. And obviously it is a bacterial problem, infection problem. You add antibiotic. We add third generation cephalosporins. So this is about epiglottitis. Right? Okay, so this is about epiglottitis. Now let's move to pertussis. The second infection, pertussis. So pertussis, whooping cough. Whooping cough. Pertussis, whooping cough. So it is a bacterial infection. What is the bacterial responsible for this pertussis? The cause is Bordetella pertussis or parapertussis. So Bordetella pertussis, parapertussis. Highly infective condition. A secondary attack rate over here is close to 100%. Right? So it is a highly infective condition. They ask about the incubation period. So incubation period over here is around 7 to 14 days. 7 to 14 days is the incubation period. Right? Now let's move on to the clinical feature, which is very important for your exam as well as whenever you encounter such a case in emergency. So when you talk about the clinical features, we have three phases over here in pertussis. The first phase is catarrhal phase. Second phase is paroxysmal phase, and the आगे we're back. ठीक है मैम, कंटिन्यू कीजिए आप. Okay, I think we are back. There were some technical issues. Sorry for that. So we were discussing pertussis, whooping cough. We discussed that the cause of pertussis is Bordetella pertussis or parapertussis, and it is a highly infectious disease. Secondary attack rate is 100%. Incubation period is 7 to 14 days, and we were on to discussing the clinical features. I told you that the clinical features to which the child can present to us, this is actually the course of illness. So firstly, the child presents with catarrhal phase. In catarrhal phase, what is going to happen? Just cough, cold, like upper respiratory tract infection like features would be there, right? And that would last for closely 1 to 2 weeks. Then comes the typical phase, paroxysmal phase, where you see this whooping cough. What is exactly this whooping cough? We will discuss. And lastly, there is convalescent phase, where the child is now improving. So firstly, catarrhal phase. And catarrhal phase, what do you see? You're going to see cough, just like upper respiratory tract infection. This will present, and this lasts 1 to 2 weeks. And then comes the paroxysmal phase, which is the actual characteristic phase where there is एपिसोडिक पैरोक्सिज्म ऑफ कॉफ, एकदम से झटके से खांसी आएगी, वन सडन एपिसोड, पैरोक्सिज्म एपिसोड, एंड दिस कॉफ is with a whoop. What is whoop? There is an inspiratory gush of hair against the partially closed glottis. So after coughing, the child will have a whoop like feature, right? So there is episodic paroxysm of cough with whoop. What is this whoop? There is sudden inspiratory gush of air against partially closed glottis. Right? And this cough is such a violent cough. The child can sometimes vomit out. The child can sometimes vomit out with this coughing. Right? The child can vomit out with coughing. There is post-tussive vomiting. And because of severe respiratory distress, there can be apnea or cyanosis. Lastly, we have convalescent phase where the child is actually improving. There will be gradually decrease in the intensity of the cough, the frequency of the cough. And this can take up to 6 to 10 to 12 weeks. Right? So this is about the clinical features, the phases. Now let's move to the complications. What are the complications that are associated over here? The first complication is otitis media. Otitis media. So we see otitis media, and there can be pneumonia as well. So pneumonia with severe cough. Because of this violent coughing, there can be pneumothorax, pneumomediastinum collapse, subconjunctival hemorrhages, epistaxis, inguinal hernias, rectal prolapse. And in CNS, important complication is encephalopathy and seizures. Seizures and encephalopathy. It is a bacterial infection. So treatment obviously would be antibiotic, and for the cough, we will going to cough and the toxicity, we are going to give supportive therapy, ensure good hydration, oxygen if required, nebulization, and finally antibiotic. Here the antibiotic we gives are macrolides. You all know what are macrolides: erythromycin, clarithromycin, azithromycin. So macrolides, erythromycin, right? Clarithromycin. So this is all about pertussis. Now let's wrap up the session with a small topic of foreign body aspiration. So it is a very important cause of respiratory morbidity in children, and usually the exploratory age group of 1 to 4 years, you see this foreign body aspiration. What is the presentation? Acutely this child can present to you that suddenly the child has aspirated and there's choking. So there will be choking, gagging, and localized wheezing could be appreciated because of the blockage of that particular airway. Sometimes there can be a subacute phase. What happens after these initial symptoms? The child can become asymptomatic. So a subacute presentation can also be there. Now the clinical features with the child can present to you depends upon the severity of obstruction. If the obstruction to the airway is a partial obstruction, then what will happen? The air can go inside but cannot come out. There will be a ball valve effect. So what will happen because of that partial obstruction? The air will get trapped. So there will be a localized hyperinflation in that portion. And if there is a complete obstruction, there will be complete collapse of the lung. And this complete collapse, if persisting for a long time, there will be development of bronchiectasis. The diagnosis here is definitely on the basis of history and clinical feature. We can also go for X-rays, CT scan to look at the particular hyperinflation, atelectasis, and localizing the foreign body. The definitive diagnosis is by bronchoscopy, rigid bronchoscopy we do, that is confirmatory and therapeutic. So management is nothing but gold standard rigid bronchoscopy. You go inside the airway and pick that out. And antibiotic can be added if superadded infection or pneumonia is suspected. The complication here definitely are going to be recurrent pneumonias, chronic wheezing, and prolonged obstruction can cause bronchiectasis. So with that, we come to the end of the session. I hope the session was fruitful. There was a lag in the end. Sorry for that, but I believe this is going to help you in your theory exam. For other subjects also, you can explore our MedEd app, explore the Farre section for your theory exams, and I hope this was helpful. Thank you and have a good evening. If there is any doubt, I will be more than happy to clear that. Otherwise, I'll take a board. Yeah, there can be long-term effects, but very minimal with inhaled corticosteroids. If used judiciously, corticosteroids do wonder in asthma patients. Yeah, a calculated thing has to be done. Inhaled corticosteroid definitely are going to have lesser side effect as compared to the oral steroids. So earlier oral steroids were preferred, given, but now we prefer inhaled corticosteroids, and if regulated we take risk benefit ratio, right? So better to use than to have such activity limitation. So thank you everyone, thank you for being so cordial. Have a good evening. I'll take a